Dr. Baier, it's a pleasure having you here. I wanted to say, first of all, thanks for taking time out on Sunday to do this. I know it's not, a lot of people, that's your own special time, but we appreciate having you here. And I wanted to just kind of get an update from you and see how things are going with you. I know you moved, last time I talked to you, you were in process of moving to San Diego to work with Brian Lenskis in that clinic there. And I assume now you've been there for 6-8 months now or something like that. And wanted to see how things have panned out so far.
Well, yeah, I'm loving San Diego. I love the weather here, especially. It was nice spending a winter here opposed to Chicago. I'm actually in the process of kind of transitioning. So I did move here to work with Dr. Lenskis, and we started Low-carb MD San Diego, and it was kind of a hybrid of direct primary care, and we were doing some metabolic health and weight loss, but I decided I wanted to transition my career mostly to focusing on metabolic health and weight loss. So I'm going to be starting with a completely digital company coming up, and we're going to focus on metabolic health exclusively. And so I'll be making a big announcement in the near future about it. So yeah, so kind of transitioning, always looking to see what else is going on out there. But Brian's going to continue with Low-carb MD San Diego, and he focuses a lot on primary care and doing that for residents of California, and he can do telemedicine and everything as well for California. So yeah, we'll see what the future brings.
Yeah, I mean, I think that's wonderful. I mean, I think, one of the things you find out is with the digital platforms, you're not as constrained by, I mean, there's some pros and cons to that. Obviously it's hard to lay hands on people digitally. I mean, you can kind of there's a lot of feedback we have right now. And, I think there's things you can certainly do that way. Will this be something you're attempting to do nationwide? Will you be able to have access throughout the country? Is it going to be, do you have to get a license in a whole mess of states? I know there's a guy named Troy Collation who does stuff like that. We're going to have him on again here in the near future, but is that kind of the model you're looking at basically?
Yep, exactly. We're going to be nationwide, all 50 states, hopefully soon. I'm in the process of applying for a bunch of different medical licenses. I have Illinois, California. I just recently got Texas last week, and there's about 7 or 8 others in the pipeline. So yeah, really trying to get more of a nationwide presence. And I was really hopeful with COVID that some of the state laws and requirements would be relaxed on a permanent basis, but it doesn't look like that's shaping out to be the case.
Oh, they're not. I was wondering about that because they made it easier to obviously practice across state lines and do the telemedicine. Are they starting to scale that back now, or?
Yeah, you know what? Actually, I forgot Florida. I do have telemedicine privileges in Florida right now too. So, but yeah, they are. I think there's only like 13 states left that are allowing it, and I think those are even limited right now. There's a deadline coming for when they're going to revoke the emergency privileges for licensing. So, but who knows? We'll see.
And there's correct me if I'm wrong, but there's like a telemedicine state compact which encompasses 25, 30 states. I think if you get one, you can get them all. Is that correct?
Yes, that is very helpful too, especially trying to move my practice to be completely virtual. That helps. And with metabolic health and weight loss, that is practical. I think you can still provide the standard of care and even excel on a digital platform. Direct primary care, it is a little bit harder to be completely virtual. I mean, sometimes you have to auscultate the heart. You have to listen to someone's lungs and do an exam. But for metabolic health and weight loss, I think you're completely good to go being digital.
Yeah, and I'm assuming model you'll have I guess remote sensing devices, scales, blood pressure. I mean, I know that's what some other folks are using. Is that part of the plan?
Yep, exactly. And it's fantastic now. We can monitor people's heart rates, blood pressure, weight, and it all syncs to the electronic medical record. So, it's not just checking in on them during their appointment. We can kind of peek in at any time, which is fantastic. It gives us an extra opportunity to intervene before a big problem develops or identify something before, it gets to be an issue where they end up in urgent care or the ER.
Let me ask you, I mean, most people understand the concept of obesity. That's generally something we can see, but metabolic health is something that is maybe a little bit more nuanced. And surprisingly, a lot of physicians don't talk about metabolic health. I mean, I mean, you and I mean, this is something we've been living and breathing for many years now, but just to kind of maybe touch on, what do you mean by metabolic health? How do we measure it? How do we fix it? What kind of things are you going to use as that's for, and for people that may be listening that have never heard about metabolic health and don't understand the concept?
Yeah, so metabolic health it's really encompassing all the diseases that go with lifestyle. And I think obesity is really one of the main ones there. But when we think of metabolic health, it's prevention of things like metabolic syndrome. We want to have your waist circumference at a level where it's not going to increase your risk for diseases like fatty liver. We want to have a normal fasting glucose level. We don't want you to be at a level where you're having hyperglycemia, puts you at risk for prediabetes, diabetes, even insulin resistance. And insulin resistance develops about 10 years prior to where we start seeing hyperglycemia, which is a huge window of opportunity to intervene. And all of that affects blood pressure, dyslipidemia, or unfavorable cholesterol profiles. And all of it ties in together in metabolic health. And, usually we diagnose metabolic syndrome by having 3 out of 5 components of some criteria, which include waist circumference, blood pressure, triglyceride levels. I can't remember, did I say blood pressure, and just other parameters, but they all tie together and they're all related to weight and inflammation in the body. I think most people think about weight loss to get healthy, but I think the right way to think about it is to get healthy to lose weight. And by healthy, I mean improving your metabolic health, having a normal blood sugar level, having a favorable lipid profile, decreasing your visceral fat so you have a normal waist circumference, things like that. And blood pressure typically follows insulin levels. When your insulin levels are high, it's telling the kidneys to reabsorb water and sodium. So when we bring down your insulin levels, resolve that insulin resistance, blood pressure normalizes. It's all tied in together.
Yeah, just a follow-up question on the actual practice. Somebody's asked me about health insurance. Is that something you'll be set up to take or no?
Yes, we are working on it. Yeah, absolutely. So right now, Medicare is a little tricky at that point, because what I'll be focusing on really is weight loss, and we will be using a combination of lifestyle. We'll be employing health coaches and everything, and physician oversight, obviously, and labs. But we do use medications, GLP-1s specifically, and those can be very expensive out of pocket. So we do use insurance for that as well, and to cover lab costs and things. But again, I won't be doing primary care where it's going to be billed in kind of the traditional model most people are used to.
Are you going to be sticking around San Diego to do this, or are you going somewhere else?
Yeah, I'm going to be staying in San Diego for a while. I really like it here. It's hard to beat the weather. I don't know. I contemplate, going to Texas at some point, but we'll see if that happens.
I lived in Texas for 20 years. I like Texas, particularly Central Hill Country. I mean, of course, there's the coast I live on there, but it's pretty freaking humid. I can tell you that.
Yeah.
I'm actually moving out of California up to Washington State here this summer, so I'm going to the cold weather. So kind of doing the
Oh,
opposite. It's more of my partner's, my girlfriend's job sort of dictates that, so we're doing that. Hey, let me ask you about the GLP-1 agonists.
mhm.
This is something that has come along recently in weight loss. I mean, there's been drugs over the years. Can you talk about what it does, why it's favorable, who it's beneficial for, and is it some people say some people might have to be on it permanently. I mean, what are your thoughts on those things? GLP-1, so it's a glucagon-like peptide, but
Yeah.
what do we know about GLP-1 GLP agonists, GLP-1 agonists?
Yep. So kind of backtracking a little bit, historically, a lot of weight loss medications have been stimulants like your phentermine, and they come with a lot of side effects. People feel anxious, heart palpitations, dry mouth, they develop insomnia, and most of them are meant to be used in like 3-month cycles. And then we had some newer ones that have come out recently, or Contrave and Qsymia, and they're combinations of medications. GLP-1s have been around for over 15 years, and they were used primarily to manage diabetes. GLP-1, as you mentioned, stands for glucagon-like peptide 1, and these are agonists, and it's a peptide hormone that's naturally secreted by the intestines in response to food that we eat, particularly carbohydrates or glucose. And they do have a role in, they're incretins. They stimulate insulin production, but they have a multifactorial effect on the body. And part of it is they interact with the hypothalamus. And the hypothalamus really acts as like the weight thermostat for the brain. And it determines someone's set point weight, high or low, good or bad. People have a weight that their body likes to be at. And GLP-1s interact with the hypothalamus in several ways. And the most noticeable for patients is that it really reduces their appetite and cravings. There are some talks about where it can actually help lower the set point weight too. And I know weight loss medications, people have some very strong opinions about them either way. And I like to make patients aware, the medications are not a magic solution. If you take the medications and don't change your lifestyle, you might lose a few pounds, but they're meant to be used in conjunction with lifestyle changes. And one of my, favorite diets, obviously, is a low carbohydrate, anti-inflammatory. I personally eat a meat-based diet for multiple reasons, not just for weight control, but for autoimmune disease and everything else. But I think the GLP-1s really shine in terms of how they can decrease appetite and cravings, making it easier to stick to the lifestyle changes initially. When you have someone that's been eating the standard American diet for 30, 40, 50 years, like the cravings they get are intense. They probably have leptin resistance. They're not getting the proper satiety signaling. They probably have insulin resistance. They might have diabetes. Again, when insulin is high, it puts a lock on your fat cells. It prevents lipolysis. So all fat is stored energy, right? It's energy we've consumed that we have not needed to burn yet. But when our insulin is high, we can't tap into those fat stores. So people feel hungry and they're chasing glucose all day long. So I think the GLP-1s are really, really helpful for people that are struggling with cravings and appetite. And then once they've adhered to the dietary changes and lifestyle changes, their leptin resistance resolves, their insulin resistance resolves, their body's able to kind of go back and forth between burning fat and glucose, whatever substrates available, they do much better with appetite and cravings. GLP-1s are approved and safe for long-term use. They're meant to be used as a treatment for chronic disease, just like blood pressure or cholesterol. Now, with that being said, I understand a lot of people don't want to be on medications indefinitely, and there is the possibility of weaning off of them, absolutely. But people typically do notice that their cravings and appetite do come back, and there is a bit of a rebound weight gain. What's unique about the GLP-1s, though, is that people are not regaining all the weight that they've lost. And as you know, when people lose weight, maintaining weight loss is almost harder. And that's because the body has mechanisms to get back to that set point weight. It increases ghrelin, the hunger hormone. It decreases your GLP and your leptin, which are satiety hormones. It decreases metabolic rate. So all of these factors lead to weight regain. So that's where the theory is behind the GLP-1s, that they're thought to lower the set point rate, so your body is not firing off these hormones and chemical messengers that are indicated for regaining weight. So it's complex, and the GLP-1s are really multifactorial, but I do think they have a role in weight management for sure, and I think they're a great medication overall.
What's the downside? I mean, everything's got a side effect, right? So, and I wonder, because GLP-1, it stimulates insulin secretion by the pancreas. it may be more potent stimulator than perhaps blood glucose itself, based on some of the reading I've done. And so, because you mentioned that insulin is going to prevent lipolysis, but you're using a GLP-1 agonist to stimulate insulin. So I'm just wondering
Yeah.
what are the potential downsides of GLP-1 agonists if somebody's concerned, you know, maybe it may or may not outweigh the risks or the
Yeah.
benefits.
So the first thing I look at are the contraindications. There was a rodent study that showed a possibility of a risk of medullary thyroid cancer, which is pretty rare. Thyroid cancer we hear about, but most of it's papillary or follicular even. Medullary thyroid cancer is extremely rare. Um, there was a study shown in humans where there is less than 0.5% increased risk of acute pancreatitis. So someone with a history of recurrent pancreatitis, I would not recommend GLP-1s to. And the most common side effects that we see with these are GI side effects, primarily nausea. The good news is it's not dose dependent, and it usually does resolve over 2 to 3 weeks regardless. Typically doing a slow titration process can help minimize that. And then anytime there's rapid weight loss, you're at increased risk for gallbladder disease, particularly gallstones. So do GLP-1s increase that risk? Not necessarily, but if you're losing weight, you're changing your lifestyle, you're on medications, it is going to put you at a higher risk in general to develop gallstones. As far as using them, so Saxenda is FDA approved for weight loss. It's liraglutide is the generic name. Semaglutide should be FDA approved probably later this summer, which even has better results than the liraglutide. But what I'm seeing personally is it's really not a great diabetic drug. Very modest improvement in glucose and insulin when it's not combined with lifestyle changes. And it is interesting, and I think it does kind of go to show we still have so much to learn about the metabolic system and weight loss, because it is, we know GLP is an incretin, but it's been, we're seeing labs where people's insulin is decreasing, their glucose is under better control. And is it from the lifestyle changes? Is it from the medications? What's going on? So I don't know. I mean, not everyone's a good candidate for it, but I think for those who are, it can be a very helpful tool.
Yeah, somebody just asked a question about what's considered a good lipid panel. I know that's a common topic, but what are your thoughts on, lipid panel? I mean, obviously, if I go on a low carb diet, a meat-based diet, there's a chance my LDL may increase. Typically, we see triglycerides going down, HDL increasing with that. Typically, not always, but how are you assessing lipids right now? Because I mean, obviously, you're a proponent of low carb, and that's one of the knocks is sometimes people end up with higher LDL cholesterols. What's the way to look at this? I guess I look at it a more holistic way, or overall risk package. But how do you look at that?
Yeah, so very similar to you, Sean. So I think in modern medicine, we've become so focused on looking at one number and treating a number. If your LDL is high, you go on a statin. And I think it needs to be interpreted with context of other labs. Maybe someone who is diabetic with a hemoglobin A1C of 12, someone who has really high triglycerides and really low HDL. If they have a high LDL, yeah, I'm going to be a little more concerned. Someone that has a high LDL with a triglyceride to HDL ratio that's 1 or less than 1, who's non-diabetic, I'm not worried at all. You can do like the NMR lipid profile. You can look at the particle size and count, and you can look at like apolipoprotein B and lipoprotein A and try to risk stratify. You can get a coronary artery calcium scan. But the other thing to remember too is that when people are losing weight, their LDL typically increases too. So if I get an LDL at baseline before just before we're doing any interventions, and I see it trend up, but everything else is improving, I watch it for a while. And then when their weight stabilizes, typically you see the LDL come down. Now, yes, there are some people that do a meat-based diet or go low carb and really increase their fat, and their LDL goes up and it stays up. And again, I it's such an individual basis, but typically if everything else is looking good, low triglycerides, high HDL, non-diabetic, zero on their CAC or their coronary artery calcium scan, I'm not worried at all.
You had mentioned insulin resistance early on, and we have this. And I had the fortune of talking with Ben Bickman. I'm sure you're familiar with Ben, but we talked about insulin resistance, and there's this sort of phenomenon of what people have been calling adaptive glucose sparing or physiologic insulin resistance. Going to low carb diet and fail an oral glucose tolerance test. And he actually reminded me, or actually corrected me, and said, "You're not actually insulin resistance in that case. You're carbohydrate intolerant. But if you give those people insulin, their blood glucose plummets." I mean, this is, so you're not, even though you don't do well with an oral glucose challenge, you're still insulin sensitive. And so I thought that was a very interesting nuanced point that I had not learned, I had not heard before, which I was kind of like interested. I mean, I'd seen Cahill's done work with that, but I didn't put those two and two together. How do you, I assume as part of your lifestyle, I mean, is your default a low carb diet, or how do you approach the typical patient?
Yeah. So it's complicated in terms of, I do think there's more than one way to be healthy. And again, I take it on an individual basis. And I was with Brian in the private practice. Like, for example, I have autoimmune disease. I have lupus, and I was paleo for a while, then I was keto, things got better, but it wasn't until I was carnivore where my lupus symptoms really resolved. And then since then, I've tried to expand a little bit, but I'm still extremely selective with what I eat, and definitely low carb. Most of the time I'm in and out of ketosis, even though that isn't my goal necessarily. So I think we have to look at the patient and what we're trying to accomplish. If they have autoimmune disease, if they have Crohn's or ulcerative colitis, I think doing an elimination diet, and carnivore's ultimate elimination diet, serves them very well. And then there comes a point where people, for whatever reason, they want to try to expand. Maybe we've repaired the integrity of the gut lining, identified food sensitivities, and I think that's great. But for the general public, like 88% of the country is metabolically unhealthy. They have some degree of metabolic dysfunction that usually stems from insulin resistance. And I think once you get to that point, so 88% of adults in this country, I think, do well with a lower carb diet. And then there's nuance. What is low carb? I'm not necessarily talking about keto, but like the average American is eating probably 300 to 400 grams of carbohydrates a day, and crap carbohydrates, right? It's processed sugar and just nothing that's providing nutritional value. And I think, lowering the carbohydrate content to whole foods, I'm even okay with certain fruits for patients if they aren't too diabetic, when it's paired with protein and fat to slow absorption. And even some vegetables, if people can tolerate it, if they don't have GI issues. But I think most people in general do better with a lower carbohydrate diet. And the nuance comes to how many carbohydrates can a person tolerate in a day. And then we can manipulate it with food pairing. Like if you eat your protein and fat first and eat carbohydrates after, it's going to prevent that glycemic spike. And that's really what I want to see. I don't want to see the huge glycemic variability that's going to cause inflammation and disruption of the glycocalyx and everything. So personally, I'm a huge fan of lower carbohydrate diets.
One of the things, and maybe you saw this, David Ludwig was senior author on a paper that came out looking at regional cerebral blood flow in these satiety appetite centers. One of them was in nucleus accumbens. And what they demonstrated was that as you drop the carbohydrate content lower and lower, you had less blood flow in those areas. Presumably that means maybe less appetite, less hunger. Have you seen that to be the case? When you say, you've got a patient on X, Y, or Z diet, that lower carbohydrates tend to result in better hunger appetite control?
Absolutely. And I can't say, I'm not going to lie and say I've seen like randomized control trials showing this, but anecdotally and just working with patients, absolutely. And there's several different theories as to why hunger and cravings are better controlled with lower carbohydrate diets. Is because There's glucose stability. You're not having these spikes of insulin and glucose all day long. Is it because there's less of a dopaminergic response in the nucleus accumbens? And we even have a weight loss medication called Contrave that is a combination of naltrexone and bupropion that is targeting that area and decreasing the reward response. And we do know that there is, I mean, processed food addiction, sugar addiction, it's real. And binge eating disorder, it's real. And I think that really does stem from processed food and sugar. So I do agree with that completely. I think that there is a reward circuit, and particularly from dopamine secretion, in response to higher carbohydrate foods. And when high carbs, like sugar, is paired with fat, I think that's when people really get into trouble and have a problem controlling it. I'd like to tell my patients, you can be high carb and low fat, or you can be high fat and low carb. But when you combine carbs and fat together, it's a recipe for metabolic disaster and weight gain.
Yeah, one of the things is, you've got, certain tools at your disposal as a physician, different medications, different measuring devices, different labs and stuff like that. But one of the things I have found, and this is one of the whole rationale behind this MEAT-RX thing, is a support system is often essential for long-term success. And is that part of your calculus on how, because it's easy to, hand a patient a bunch of papers and say, do this, and this, but you can't hold their hand every day. And so how do you negotiate that part of the game?
I cannot agree with you more. I think having support in a community setting, if it's like through a Facebook group or MEAT-RX, or, individual coaching with a health coach one-on-one, some form of accountability is crucial. And weight loss is so complex, and you're absolutely right. You can't just give someone information and send them off, tell them to go do this. There's going to be questions along the way. There's going to be doubt. There's going to be frustration. There's going to be highs and lows. And the community support is crucial. And I think even like what you're doing on social media and on Instagram, people need to know they're not alone and that they have like a leader, someone to kind of look up to. And I think that's imperative. I mean, I'm sure you've counseled people before. There's going to be days where, your friends are giving you a hard time, your family's giving you a hard time. Why are you eating ribeye, 5 days a week? Why are you eating eggs? I thought that was going to kill you. They need to know that there's someone who has their back, who they can turn to, who has similar commitments and similar goals and similar success. And it's really just strengthening the community that I think is really going to propel this movement forward.
Yeah, my response to why are you eating ribeyes 5 days a week is, why aren't you eating it 7 days a week?
Yeah, I'm all for that.
Hey, I want to ask you, because you're obviously approaching metabolic health. What's the time course? I mean, how quickly can someone see because one of the, I don't know if you want to get into this, but one of my, and I'm not the only one that's sort of been there, but one of the criticisms during this pandemic response is we have not addressed the primary risk factor for most people for this, and it's metabolic health, obesity. And it was just like, there's not enough time. And we've been here now, we're 15 months into this thing or whatever it's been. And that's, so how fast can you impact metabolic health?
Days. Within days. Fatty liver disease, we can reverse. And if you do some intermittent fasting and a low carbohydrate diet or a carnivore diet, you can reverse fatty liver disease within days. And this has been confirmed by bariatric surgeons. It's not just on imaging, but when you're actually visualizing the liver during a surgical procedure, you can see the resolution. Glycemia, it really depends on the severity, but we see improvements in glucose, even in diabetics, type 2 diabetics, we see improvements within a week or two. I think there are a lot of other ways, you can accelerate the process. Again, some intermittent fasting or time restricted eating, exercise, especially high intensity interval training, is going to deplete your glycogen stores really quickly as well. That's going to improve your metabolic health. And, you're going to see metabolic changes before the scale moves. So people get frustrated and think, I'm only losing 1 pound a week. It's going to take me 6 months to get down to a healthy weight, whatever. And like you said, I mean, now it's been 15 months. If they had started at the beginning, they'd be in a completely different position. But in terms of immune function and metabolic changes, you see changes start to happen within days and really measurable within a couple weeks.
Yeah, I'm not surprised by that response because I've seen the same thing myself. But let me ask you about, just because there's often other physicians listening to this, personal satisfaction with what you do now relative to maybe practicing in an older way. I mean, obviously you left what you're doing for a reason, but what's the difference in your own sort of, in your satisfaction with what you do now?
Oh gosh, going back, the whole model of what I was doing with Brian, we got to spend a lot more time with patients in a direct primary care setting, and weight loss, and that was just really nice. Actually, getting time to educate patients, and I'll be doing the same thing, like 45-minute visits. With patients. So just having time to educate patients is great, but really with that comes their success. And instead of watching people get worse and worse in terms of disease progression, you start to see them improving. And now I'm de-prescribing medications. I might put them on a GLP-1, but they might come off of their blood pressure and diabetic medication. So we might add one, but take away 4 or 5. So it's really rewarding. And you just feel like you're actually doing what you set out to do when you started medical school, which is help patients and improve health. And I really enjoy educating patients now too. Like, of course, obviously it's a business. We need them to come in and see us, but eventually we want them to be able to do this on their own and have the tools to live a healthy lifestyle that gives them the energy to do the things they want to do in life. It's, really not just about weight loss. It's about vitality and being a good, friend and husband, wife, mother, father, brother, sister, what have you. And that part is really rewarding. I had a patient a couple weeks ago who came in. We diagnosed her with diabetes, newly diagnosed diabetic. Her hemoglobin A1C was like 14, hadn't been to see a doctor in years, had struggled with weight most of her life, but it really just accelerated the past couple of years. A few months in, she's lost some weight. Everything's improving. She was carnivore, and I didn't put her on any medications except metformin. That was the only one she was open to. And she said for the first time she was able to play badminton with her grandkids, and she was crying as she was telling me that. And it was just like, it just doesn't get better than that as a physician when you feel like you're helping someone get their life back.
Yeah, before, as I saw it, it was almost like kind of watching a ship slowly sink into the ocean with, you just watch them go down, 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 and you're like, well, we know we're going to increase this medication, and you kind of, you kind of saw the same story over and over. It's like watching the same movie over and over again, and now it's different. What you mentioned autoimmune diseases, and I know that's not your focus, but are you seeing, this is the one thing that I hope that the low carb community wakes up to, and I think some of them are. You talk about weight loss and you talk about diabetes a little bit, but there's so much more that seems to benefit from diet. And, I remember there's just people talking about, mental health disease. How dare you suggest nutrition has a role in mental health disorder? It was all due to my childhood trauma, but that's, it's kind of crazy. Have you seen improvements in a wide variety of medical conditions? And if so, can you discuss some of them?
Yeah, absolutely. So I think just, from being on podcasts and talking about my own experience, I've attracted patients with autoimmune disease or these vague symptoms, traditional doctors that have 10 minutes have not been able to figure out. So the biggest things I also had migraines. So migraines, I feel like I have a good method down, mostly. And big component of that is diet, an anti-inflammatory diet, stress, sleep, caffeine, artificial sweeteners, those got to go. But migraines, I feel like we can definitely improve with lifestyle. Um, Eczema is huge. And eczema, I actually had a patient teach me this who she had spent a lot of time in Europe, and apparently where she was, or maybe it was Albania, the way they treated eczema was with very high dose of fish oil. And I mean, fish oil supplements here, 1 to 2 grams. I mean, they're putting people on 8 to 10 grams of fish oil and getting rid of dairy and grains. And it improves. And I was like, well, I'll give this a try with a couple of my eczema patients. Sure enough, like improved significantly. But Crohn's disease and ulcerative colitis, and even IBS that isn't necessarily inflammatory bowel disease, 100% we can improve that with dietary changes. Depression, anxiety are two other huge ones. Even bipolar and schizophrenia. I love the work Chris Palmer is doing out at Harvard. And, I have a friend whose son who is struggling with mental illness right now. And they are, advocates for a ketogenic diet and have seen a lot of improvement despite some of the setbacks that the medications have caused. Anyone who's worked with patients suffering from mental health issues, like the medications are almost worse than than the actual symptoms of the disease. And I think diet plays such a huge role in even decreasing the neuroinflammation. And I think a diet that's anti-inflammatory, that's completely eliminating processed food, is going to improve psychiatric disease regardless.
I just had one of our members commenting that she, 20 years of keto and she still had autoimmune issues, but she switched to carnivore and they all went away. And so obviously there's something there. And I like the fact you said some people, vegetables irritate their GI system. And that seems to be the truth. I apologize. My dogs are barking in the background right now, but hopefully I'll quiet down here in just a second. Let me ask you about, so these low carb diets, what are the downsides that you've seen? Because, everything's got an up and down. Have you been seeing many downsides or struggles or issues with them?
Yeah. So the biggest criticism of low carb or keto and carnivore is that it's not sustainable. And I like to argue that. And for some people, it's more psychological. And once they actually adhere to the diet for a couple months, they feel so much better. Their cravings have dissipated and they can't imagine going back. Now, for some people, that isn't always the case. And I think being very strict at the beginning and even doing, exposing yourself to like cognitive behavioral therapy. And I'm not talking about in a formal setting with a therapist, even though that's a route too, but just changing habits. Atomic Habits by James Clear is one of my favorite books. The Beck Diet Solution by Judith Beck, which is basically cognitive behavioral therapy over 60 days. It's getting you in the mindset to change habits. And I think that's very helpful in combating the issue with compliance long-term for people. But I can't say I've seen a downside medically speaking to a low carb diet. Like we touched on before, some people do have an increase in LDL, but all of their other cardiometabolic risk factors improve. I don't know what 20, 30 years down the road is going to look like, but I would be shocked if there is an implication for it.
Yeah, the diet you mentioned, the Beck diet, is that the same person who's the Beck Depression Index is named for, perhaps? I don't know.
Yeah, you know what? I think it's his daughter. It's like a whole family. And Judith Beck, yeah, I think it was her father who did who's like kind of the godfather of of all of that. And then Judith Beck is a PhD, but she really focuses on cognitive behavioral therapy and behavior change. And, her diet book, it's not your typical diet book. She's not telling you what to eat, what to do. She's really talking about the psychological changes. And I feel like with a lot of my patients, that's the hard part. It's breaking the binge eating cycles and emotional eating and the way we use food to cope with negative emotions, which is not often talked about, but is extremely important for sustainable weight loss.
Yeah, it's one of the first things I talk about when I deal with folks. I said first thing is to change that relationship with food. If you don't do that, you're not going to have a long-term, you're not going to have a long-term solution. So I think that has to be primary goal number one, or at least that's how I approach it. When you, what was I going to ask you something about? Do you find that so if you do have people with elevated cholesterol, I mean, how do you approach those people? I mean, do you further, is it, to me, I look at it, this is maybe a potential red flag, let's investigate further. There's other people out there says, I don't care, don't worry about it, but I don't find quite that to be the right answer. So how do you work up somebody that comes in LDL cholesterol at 250 or something like that?
Yeah, that's a great question. And every patient is different. You have, the nice thing about social media and everything is people are exposed to so much information. And I'll say a lot of my patients come in with their mind already made up if they want a statin or not. And the overall consensus in the low carb community is statins are horrible. And there is some data to back that up. It increases your risk of diabetes, actually. I mean, I've seen patients develop hyperglycemia as soon as they go on a statin. It can increase your risk of dementia. It inhibits HMG-CoA, and there's a downstream effect to it. With that being said, though, there is a time and a place for it. If someone has a very high coronary artery calcium score and very high triglycerides, and they've been diabetic for 20 years, yeah, I'm going to have a very serious talk about going on a statin for them. And it can help stabilize plaque. So I think informed consent is the most important thing we can do as a physician, which is, largely forgotten right now, right? I'm going to walk them through and explain the risk and benefits. There is a website, it's the Mayo Clinic Statin Decision Aid. And it's pretty cool. You can put in some parameters, like I think the patient's age, their blood pressure, smoking history, and then you can, click on different interventions, a low dose statin, a high dose statin, and it'll show you the relative risk reduction or absolute risk reduction. So, if I walk the patients through that, explain the risk and benefits, it's up to them to decide what they want to do. But again, I think it needs to be taken into context. And I'm not just looking at their LDL. I want to see the triglyceride to HDL ratio. I want to see if we have a lipoprotein insulin resistance score. I want to know if they're diabetic. And, again, asking the patient, like, are you willing to change your lifestyle? Do you think this is something you can do, you're willing to do? Most of the time it's yes. And then you have some patients that are like, no, Monday through Thursday, I can do it, but weekends, I'm not going to stick with it. And it's like, okay, then, we might need some pharmaceutical intervention there.
Ask you a little bit more about the practice. Are you like, do you cap yourself? I'm going to see, in panel X amount of patients in there. And then is it kind of more concierge type of thing, or how do you decide how often to see them? I mean, obviously going to vary a little bit from patient to patient, but is there a typical, I mean, you take somebody, they're broken, then you fix them, and then maybe they don't need you anymore. I mean, that's ultimately the goal, I think. But how do you currently have it set up?
Yeah. So at Low Carb MD San Diego, what we did is we had a 16-week weight loss program, and we would meet with patients every week or every other week. Plus we do like community Zoom meetings and things. And then for our direct primary care patients, it was unlimited access. So it really is a concierge model. And you have some patients who want to meet every every week, who are emailing every other day, which is fine. And then you have some patients you hear from, every 6 months because they want to check some blood work. So, that's the beauty of concierge medicine. You have access to your doctor and your medical team when you need it, and when you're healthy, you're great. So yeah, with the digital platform, it's going to be set up a little differently, but again, patients would have access to their physician through messaging at all times. There won't be like an immediate response, like, being on call 24/7, but within a business day, patients can expect a response. And I think patients really like that now. It's sometimes just getting a hold of your doctor or the doctor's office just to schedule an appointment can be such a huge hassle. So, a good user experience is really going to be in demand in the future once people get a taste of this type of medicine.
I mean, there's obviously a well-established, allopathic system in place and medical boards that sort of regulate that. Do you see that this is going to be an emerging model that's going to compete, and do you think it's going to expand and grow significantly? Do you think that's where things are headed?
Yeah, that's a great question. And I go back and forth in my mind. So there are many benefits, and I firmly believe the quality of care patients are getting is better. With that being said, it is an out of pocket expense. So that does limit people, and that's really unfortunate. And um, even in areas of San Diego, we were set up in East County, and it's a working class area, and people were definitely you know stretching their budget to have access to us, which we greatly appreciate, but we know that's not doable for everyone. So I think and concierge medicine is taken off in well-to-do places. People that can pay for it utilize it. So I think we need to figure out a way to make this kind of care accessible to everyone, regardless of income. And to do that, we're going to have to bring in insurance at some point if people are already paying for insurance. But when you are being paid and reimbursed by insurance, they're telling you how many patients you have to see, who you have to take. And when you're seeing 30 to 40 patients a day, you can't spend an hour with them. Um, so I don't know what the answer is. I think the system is broken beyond repair, and we need drastic changes. And I think we're a ways off from anything really coming out of it.
Yeah, I think that one of the concerns is, yeah, I mean, how do you get the people that can't afford it? That's the thing, and I think that's a tough situation. And I think obviously the system is broken before they even get to the doctor in a lot of ways. And I think obviously reforming our food system, I think is going to be a part of the essentiality. Now, if we have the appetite, I say that kind of pun intended, to do so, is a question, and I'm not sure that that's the case. When we're seeing that people are celebrating Krispy Kreme donuts because or beer or marijuana because I got a vaccine, it's a little bit concerning.
It is. You know what I think is an interesting avenue to explore is employer-sponsored utilization of concierge medicine and direct primary care. They're already paying for health insurance. If we can, show these employers that we're going to increase productivity, reduce sick days, decrease their health insurance costs overall because their annual exams are going to be drastically improved with these lifestyle changes and focus on metabolic health. That might be a good way to be able to include people that can't afford the service out of pocket. But you're right. It's like it really does start with food. Like food is one of the pillars of health, nutrition, and to ignore that and pretend like you can take a medication and completely ignore lifestyle and nutrition, like we're never going to get ahead of the curve here, never. And I think COVID has really highlighted that.
And also there's a large push at the global level to change our diet, and unfortunately those changes are to sort of remove nutrient dense food from the diet, i.e. meat, and replace it with more processed food. And so as a physician, I'm sure you can see the horrors of that. You wonder about, are we not going to be satisfied until 100% of the people are metabolically broken and obese? I mean, are we going to get to that point, you think?
Yeah, I mean, it's scary. It is terrifying, and I don't know what the tipping point will be. And I think healthcare costs are just gonna increase exponentially at this current trajectory. And um, I don't know. I feel like everything kind of comes down to politics and money, and I don't know what the breaking point's gonna be, but It's horrifying. It's so scary. And then you see Bill Gates buying up all this farmland and pushing pea-based proteins. And what's even more concerning to me is how many people just believe this dogma and are completely buying into like the vegan propaganda. And it's frightening.
No, I obviously I don't. What when you get a patient for the first time and they're coming from the traditional model, do they ever comment that this is better, or what are their comments typically?
Oh, it's usually so happy. The most common thing I hear is, I've never had a physician spend this much time with me, or I haven't had a doctor talk to me about nutrition and lifestyle before. In that it's sad but true. I mean, most patients spend 5 to 10 minutes with their doctor a couple times a year, and yeah, they're overall, I think they're very happy with the experience.
Yeah, and I think it's just important to point out. I mean, a lot of people complain about physicians, but I mean, physicians aren't choosing to spend 5 minutes with their patients. I mean, it's largely administrative driven, and I know when I was seeing 50 patients a day, plus overseeing two PAs and having to see their patients, and just literally running all day long, plus having to do the EMR and the coding and the billing, and it's just insane that system is even allowed to continue to exist. But the problem is we're just overwhelmed with so many damn sick people that, it's like, well, how do you see all these people? And then, it's one of those things where the insurance companies keep driving the prices down so that you have to see more patients. And so it compromises everything, I think.
It definitely does. Yeah. And, I have my friends from residency and primary care, like they're drowning and patients get upset. The doctors are burnt out, and then they go home and have 3 hours of charting and documentation and callbacks to do. And it's going to implode. It is imploding. It's not good for physicians. It's not good for patients. Insurance companies seem to be benefiting from it, but that's about it.
Yeah, like I said, I love that you've stepped outside that model, and I think hopefully more physicians will. And as you pointed out, if you find you're not alone, the nice thing about social media is you can say, hey, there's somebody else doing it, there's somebody else doing it, and get more people that have the courage to do that. As an orthopedic surgeon, you can't do that. I mean, that's not one of the options. So this is kind of a primary care field for the most part. I mean, as an orthopedic surgeon, you got to have an operating room. That's why I'm not doing that at all anymore, because I'm having more fun doing this stuff. But so has your practice actually started yet, or when does it actually physically start?
No, you know what? I'm going to be starting with them full time come May. So, I'm taking a little pause on social media right now. I just got got burnt out, but I'll be on Instagram again soon, and we'll make a big announcement probably coming up in the next couple weeks here.
And you said starting with them. Who is the them in the them?
I can't say quite yet, but I'm sorry. I know that's such a tease, but when I can, I will let you know, and I will let your community know for sure.
Okay, well, we'll definitely keep you in mind, because I know a lot of the folks here, many of them don't need physicians very much anymore. Maybe for a once in a while checkup thing, but because they're doing good. But some of them certainly do, and we like to have that support. So I assume that you're happy to see our crazy meat eaters if need be. I know
Yeah.
we have a growing list of physicians that have identified that they'd be happy to see folks like that. But
Awesome. Yeah.
anyway. Well, I'll
Would
tell
love
you
it.
what, thank you so much for taking the time, Kristin, on Sunday, and good luck with the new venture. And I wish you the best. And hopefully you get to see as many patients as you possibly want, and help as many as you can. And I think the more physicians that do that, the better.
Thank you so much, Sean, and good luck with your move up to Washington.
Yeah, we're in the I'm standing in a bunch of boxes right now. You can't see behind me. Maybe I can. I don't know. It's a room's a disaster. I'm just trying to. We're going to be loading all that stuff today. Where can people find you? I know you haven't announced where you're going to be practicing yet,
Yeah.
but where, just so they'll know where to find the announcement. Where can they go?
Yeah, mostly on Instagram. I'm at Dr. Kristin Baier on Instagram now. I used to be doctoring keto, but changed it up. So at Dr. Kristin Baier on Instagram, and that's the best way to get a hold of me. Feel free to message me, and I'll be active on there again. I check it every day, but I haven't been posting, but I'll start posting again soon.
Okay. Thank you very much. You guys,
Great.
thank you and have a great Sunday. And I'll tell you, once you get rolling into practice for 6 months or so, maybe would you come back on and tell us how it's going?
Yeah, I would love to. That'd be great.
Awesome. All right, guys.
Okay.
You guys have a great Sunday. We'll see everybody back tomorrow. Okay. Take care, guys. Bye-bye.